Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Do have some knowledge, but it's more practical than medical. My time in the military as a Navy doc and also as a Marine has taught me a lot of things about the systems that many of you are familiar with. So I don't come to you as an expert in this topic, but I do know a little bit about peds and peds trauma. And the reason we thought this talk would be helpful is almost all of you at some point are going to work with kids, whether it's in your professional life as a paramedic or in a refugee medicine, or maybe it's your neighbor. You know, maybe your neighbor's kid is sledding and smacks into a tree or something like that. So, and I have to, full disclosure, give you the kind of the nucleus of this talk, which was I was asked to speak to a bunch of adult trauma surgeons about pediatric trauma. And I said to them, well, what do you want to hear? And they go, well, I don't know. What do you think we need to know? And it kind of had a little bit of an epiphany and said, well, there are some things that they don't do very well that we see as a tertiary receiving center for peds trauma. So with that in mind, I put this it's almost like a question and answer format that I put together. There is some stuff at the end about x-rays and radiology that mostly I just like you to know, but it's not critical to your austere medicine. So sit back, relax, ask any questions you want, and we'll get started. Let me see, do I have to point it there? There we go. Okay, this is my experience over 25, 30 years of doing this. I don't have any conflicts of interest. This is not exclusive. This is all open source. Anybody can have it, and anybody can have this lecture. It's nothing too fancy. There we go. Okay, so I apologize. This is about urban trauma. I don't have any good statistics about rural trauma, but to give you an idea of what hurts kids and what kills kids in an urban setting, because that's where so many of them are seen. So if you look on the left, your left, this is the mechanism of injury. What you see here very quickly is MVA is motor vehicle accidents, PEDS is pedestrian struck, and falls are self-explanatory. I want you to kind of take away that if you in an urban environment, those are the things that hurt children. Okay? Lots of motor vehicle, and I always talk about motor vehicle related. If you think about it, being struck by a car, being hit on a bicycle, and being occupants in a car makes up a fair amount of that. And then you can see gunshot wounds, 7%. Abuse, very important in young kids, under 2, actually under 1 mostly. Stab wounds and penetrating gunshot wounds are relatively small. Now let's look to the right side, what kills kids. And the difference is important. Falls is the best one. It's 30%. So we see a lot of kids with falls in urban environments, but they don't usually die that often, not as many. Motor vehicle is pretty similar. Gunshot wounds and abuse, 10 times the number of deaths from abuse versus the commonality of it. While we don't see it all that often, it usually is pretty serious. Okay, so that just gives you an idea. Now, the numbers on the bottom, if you do the math, I can't do that math, but I'm a surgeon. It shows you that kids do really well. I don't know that number, but it's probably about 98%, 97%, something like that. So most kids survive their injuries, and that's a good thing, obviously. Yes, pedestrian struck. I'm sorry. Pedestrian struck. Yeah, autoped, pedestrian struck. And then when it says bike, it's, them struck as bicyclists. We could spend a whole lecture on this. We won't. This is just to give people an idea. Okay, are children little adults? Many of you who work with adults will say, well, they're just little adults, but they're really not little adults. And one of my goals is to try to have all of you here realize that when you leave this lecture, you won't say, they're just little adults, we treat them the same way, because they're really different. They're different for a lot of reasons. Okay, so I'm just going to talk about a few things and hopefully highlight these things. Nothing you need to write down, just an idea that, does anybody here take care of kids full time? Raise your hand. Thank God. Yeah, thank God. If you're a pediatric anesthesiologist, go out and get a cup of coffee. But we're going to talk a lot about that stuff. But the idea is many of you deal with kids, but infrequently. And so therefore, these tests and things that I'm giving you, hopefully you can kind of put away in your backpack for when you need them. Okay, so airway is everything in kids. Now, let's define children a little bit, because children can be anything from this size to bigger than all of us, right? We see all of those. When we talk about children from an anatomic and physiologic standpoint, we're really talking about kids, say, under 12, and a lot of the anatomic differences are in kids from, say, 2 to 6. You know, toddlers, young children. We're not talking about the 15-year-old who weighs 250 kilos or 250 pounds. You know, that's not kid. He may think like a kid, but he's not kid size, and a lot of his anatomy and physiology problems are different. All right, so that's just so you know, when I talk about children, I'm really talking about this size. Okay, so airway is everything. The majority of deaths in children come from cardiorespiratory failure, mostly respiratory failure. Okay, so we're going to talk a little bit about what makes kids different in terms of their physiology and their anatomy. So the head is larger than an adult, the proportion of the head. So the occiput is bigger. So what happens if you lay a child on a stretcher or anything like, it tends to flex the neck forward. What does that do? It helps, or it occludes the airway, or makes it more difficult to visualize the airway. So as a result, we tend to put a roll under the shoulders to let the shoulders come up, which allows the head to come back. Now, we all know that we're not going to flex a neck in a trauma patient without having it cleared. So we don't flex that neck. We want that neck in a neutral position. But if we just lay the child on a stretcher, most of the time it will come forward, making it very difficult to access that airway if you need to. So we call that the sniffing position, where the nose is the highest. Okay, so this is most prominent in children 2 to 4, 2 to 5. As we get older, it's a little less important, but think about it in those young children, okay? And we know, of course, we don't, we guys all know different ways to open the airway, and we talk about the jaw thrust, chin lift, all that. We don't chin lift in trauma patients. Everybody knows that. I just remind you. The neck is less well supported. What does that mean? The facet joints in a child are flatter. The ligamentous structures are not as strong. So the neck moves a lot more. Now, you would think intuitively that we would see a lot more neck injuries in children than we do in adults. But strangely, we don't. And I can't explain that difference. They're not. It's like they're like a bobblehead up there, the children. The head goes like this. But we don't see as many neck injuries in children as we do in adults. I suspect because of that laxity. You would think that laxity would make it more susceptible, but actually it doesn't. We do see injuries, but not as many, okay? The airway is smaller, more anterior, and the epiglottis is short and omega-shaped. And I'm going to show you a picture showing the differences, so we'll get to that if you don't know what I mean when I say shorter and more omega-shaped. So the airway can be more different in a child, all right? In terms of going kind of down the body, the mediastinum in a child is less well fixed, okay? It's kind of good news, bad news things. We all know that pneumothorax, we all know what a pneumothorax is, and we know that a pneumothorax can kill people because of the shift of the mediastinum. In adults, the mediastinum is much more fixed, so it doesn't shift. It takes more to shift that mediastinum. In a child, it's less well fixed. When a kid gets a pneumothorax that's untreated, that shift is real. And as many of you probably are aware, it is not the respiratory part of a pneumothorax that kills. It is the compromise of circulation. When the mediastinum shifts, it cuts off the blood supply to the heart. So in children, it's real. We see it. So the mediastinum is less well fixed. That's the bad news. Now, the good news side of that is we rarely see aortic injuries in younger children, kids under 12. That aortic disruption that you see from a deceleration injury, it's really rare. Now, it's not impossible. If a kid falls 60 feet out of a building, yeah, they can have an aortic disruption. But in general, kids under 10 or 12, very rare. And that has implications as we treat them later in terms of how much radiation do we give them, and I'll talk a little bit about that. Let's see, this way. Okay, now, I apologize for this. I came to Europe. In America, we always have to talk about going from pounds to kilos because everything in medicine is in kilos, but America is a pounds, is imperial. I guess we call it imperial. Is that right? Yeah, it's an imperial system, but the majority of you people here if you're not from the U.S., you use kilos, so you don't need this. But if you happen to need this, I'm going to show you just a really quick calculation. Now, we all know that there's 2.2 pounds to a kilo, and you can do the math, and if you're really good at math, you can do this in your head. But I have an easier way, okay? I'm doing the bottom one first, and then I'll go back to the... So the kind of the mantra you want to remember is divide by 2 and subtract the first number. And there's the example there. If somebody is 80 pounds, you divide by 2, that's 40. Subtract the 4 of the 40, 36, you'll be right within a kilo every time. And for those of us who have to work in pounds, it's a very fast way to get there, okay? Has everybody got that? Any questions about that? So you can double check it and say, well, okay, we know there's 2.2 pounds per kilo. That means 10 pounds should be 22 pounds, or 10 kilos should be 22 pounds. Okay, let's check it. 22 divided by 2, 11, subtract the first number, 10, you're right there. Now, where this has benefit, especially in the United States, is in babies. Everybody knows the weight of their babies in pounds. You know, you have a new baby. He's 8 pounds, 4 ounces. Okay, but we need kilos because all our medicines are based in that. Well, you can do the same thing. Let's say a baby is 8 pounds. All right, you divide by 2, it's 4, but you wouldn't subtract 4 from 4. It doesn't make any sense. So you take 0.4 when there's less than 10 kilos. 3.6 kilos, going to be right within a tenth of a kilo. So it's a very quick way for the silly Americans and the imperialists to use that system. Okay, another little nomogram. You come to a scene if you're working in an austere environment and there's a child and you're like, well, I need to draw meds. How much does this child weigh? And, you know, there are about 5 or 6 different ways to figure this out, and I'll talk about them in a minute, but the easiest one is a nomogram. And the nomogram that we use, and it's been pretty well validated, is a 1-year-old is 10 kilos, a 2-year-old is 15 kilos, and a 3-year-old 17.5, and it goes up after that. So all we're really doing is going 10, 5, 2.5. So let's say you come to a scene if you're a primary provider, and it's a 4-year-old who's down. I don't know how much he weighs. His mother's not available. What are we going to do? We got to draw up meds. 10, 15, 17.5. We're going to call him 20 kilos. Off you go. You're going to be fine. Okay? And then you can go up farther than that. After you get to a certain point, it doesn't matter too much. You can just kind of estimate. So that's number 1, the nomogram. Number 2, and at the risk of being sexist, find some parent in the room, usually a woman. I'm sorry. Women are way better with the weights, and because they usually take the kids to the doctors, and usually ask them. It's certainly what we do sometimes in the hospital when we're not used to. All of us who do peds, we're used to doing this weight estimation. But if you go to a hospital where you're not used to it, or you're a paramedic that doesn't take care of kids, you ask a female who's been a mother, usually they can say, yeah, he's about the same size as my nephew or my son, and I took him to the doctor and he weighed, 20 pounds or 30 pounds, whatever it is. So that's a second way to do it. Okay? And then there's the Broslow tape, which I'll talk a little bit about later, but these are all relatively simple ways you have to get to kilos in order to give medicines. Obviously, don't forget that. And I say that, and you might look at me like, why is he telling me the obvious? Well, because you'd be surprised. At least 2 or 3 times a year, we get children who are overdosed because they dosed medicines in pounds and not kilos. Okay? And they just didn't do the right thing, or underdosed, depending on it. All right. Airway management. 2 little caveats that I always like to remind non-pediatric providers. Don't assume the level of consciousness on arrival will be maintained. Now, where we talk about this in the hospital is, and if you think about it, it makes a lot of sense. A child comes in, he gets hit by a car or falls out of a window or whatever. EMS shows up. Lights, sirens, 20 adults gather around him. They tie him down to a stretcher and a board. They put a collar on him, and then they drag him to the hospital in an ambulance, and then they start sticking him with needles in an IV. That child is pretty stimulated, all right? And then, of course, in the medical field, everybody's got to have their CT, right? Everybody, in the U.S., I don't know about Europe, but everybody's got to go get their obligatory CT of their head, neck, and abdomen. We don't do it nearly as much in children as they do in adults. That's where they degrade. If they have a head injury, when they go to CT and everything's quiet and the stimulus stops, that's when, if they have a head injury, their airway can be compromised, and that's a bad place to have a problem in CT where the monitoring is much harder. So just be aware that their initial presentation may change. One of the things about children that's very different than adults is, especially from a cardiac and circulatory standpoint, is kids can maintain their pressure till they lose 25% or so of their blood volume, where adults will come down in a relatively linear fashion. Kids won't do that. Respiratory is the same way. they have compensatory mechanisms that allow them to maintain their breathing. And, you as a provider have to really look at them. One of the other things you can say is children are a great tool for learning austere medicine, because most of the evaluation we do is just visual. We don't need a lot of toys. If we're talking about the clinical indicators of inadequate tissue perfusion in a kid, is a child in shock? Well, you just kind of, what do they look like? How's their mental status? How's their pulse? How's their perfusion? Because kids are clean machines. They don't have vascular disease. If you take they will have a separation between their distal pulses and their proximal pulses. They will have cooled model extremities. They will be combative and argumentative or confused if they're not well perfused. And then the installation of some crystalloid or even blood will perk them right up. Their heart rate will come right down, and you will see a real difference. Okay? All that is, if you will, visual. You don't need a lot of toys. Okay? So that's number one. Number two is, don't assume that pulse oximetry alone will tell you of an impending disaster. All right? Kids, like I said, will splint. They will maintain their ability to oxygenate with rapid respiratory efforts, flaring, things like that until the last minute. And then at the last minute, they will crash very quickly. Remember also that children, and these are more in the under 2 and 3 year old range, their cardiac output is rate driven. You and I, anybody over about 5 or 6, we can influence our cardiac output in 2 ways. We influence our cardiac output by our rate and what we call our stroke volume, how much we pump each beat. Well, children can't alter their stroke volume. Little ones can't. So their cardiac output is all rate driven. So when you deal with children and young kids, especially peds people, we're very focused on their heart rate. Now, what screws up the adults is they look at it and they go, oh my God, the heart rate's 170. And the peds people are going, that's great. 170 in an adult would be, oh my God, it's a terrible disaster. Our disaster is when the heart rate drops in the 60s and 70s. That's a problem. That kid is about to code. They don't have cardiac disease, so they can tack away at 150, 180, 200. It doesn't mean that they're okay, but you don't have to worry about cardiac compromise like you would in an adult patient. Okay? Again, they're not little adults. So just a quick, I don't expect anybody to memorize these range, but if you take a look at these, okay, so what's a normal respiratory rate in a kid? Well, here you go. Everybody's got that, right? No, nobody's going to remember that. But what you do know is that a 15 or 16-year-old breathes about 15 or 20 times a minute, and a baby breathes about 40 to 60 times a minute, and that's all normal. Okay, if you remember those 2 things, you're all set. Okay? So we talk about respiratory danger zones. This is what I call them, 20 and 60. Okay, that's all you have to remember. But clearly the 20 in a baby, real problem. 60 in a 14-year-old, real problem. At a 10-year-old, it should be 30, 40. And if it's 60 or 20, a problem. Okay, that's all you kind of need to know. But you can assess that by just kind of looking and go, that's a baby. He's breathing 18 times a minute. That's a problem. Just like if you saw a 16-year-old or a 14-year-old and they were breathing in the 70s or 80s, you'd say, something's not right there. Okay? So easy peasy. All right, we're going to move on to some technical stuff. Again, there's nothing new about this. It's just to give you some tools. One of the biggest questions we always get, okay, we've decided we're going to intubate this child. What size endotracheal tube do I use? And in adults, it's a little easier. You kind of, let's see, they're a 7, a 7.5, an 8. That's easy. In children, they can be this size all the way up to this. So you do have to have a little bit of a formula. Okay, so I'm going to give you some little tips and tools. So what size tube do I use? Well, there's 2 formulas up here. 15 plus the age divided by 4. And you can see the example. I won't read it to you. Or you can use age divided by 4 plus 4. Either one of them works. I don't know any quick way to memorize these formulas. But it gets you pretty close. You've got a 3-year-old coming in, or you come to a scene and there's a 3-year-old, and you say, I haven't intubated a kid in forever. I don't know what size tube to use. Okay, 3, 15 plus 3 is 18 divided by 4, 4.5 tube, and that's going to get you pretty close. You'll sound like you're a peds person, Yeah, we're going to get a 4.5 tube out there. Okay, so that gets you pretty close. The other one is the nail bed on the pinky. Not your nail bed, the one on the pinky. That's also a very easy one to use. You just take the nail bed and you say, that's going to get you close. Obviously, in a child, you probably should have, if you were coming to a scene, I would tell you, if you do the bath or you use the nail bed and you say, I think a 4 tube is going to be right, have a 3.5, a 4, and a 4.5 ready, okay? The airway is a little more unforgiving in a child, and they won't, you can't do the same things as you can in an adult. So that's another way to make sure, okay, now I know. So I know how to assess the child, right? We know that they're different. We know how to assess their child. We know how to assess their respiratory status, their vitals. I should just make a quick mention about, we talked about their heart rate. I make a quick mention about blood pressure. Just like many of you probably learned in school, children are tremendous compensators. They will maintain that blood pressure like I talked about until they lose about 25 or 30%. And then their pressure drops like a stone. So their blood pressure to us is a very late finding of shock. All the what I call the clinical indicators of inadequate tissue perfusion, just the things that we talked about, cool model extremities, confusion, et cetera, that's a better indicator whether this kid is in shock than a blood pressure cuff, okay? The other problem with kids is, what size blood pressure cuff do you use? There are about 4 different sizes that you need to use in kids, and unless you have a very well equipped rig or, you're in an austere environment, it doesn't work. But knowing these things, knowing that you can assess the heart rate and everything else, and you can just palpate. Of course, do you guys do this in adults? It's a kid's thing. I haven't taken care of adults in a long time. A lot of times when I assess a child, I can actually look at their carotid and see if it's pulsing. And if I can see their carotid is pulsing, then I usually know their blood pressure is pretty well. Plus, their perfusion is pretty easy to figure out. If they're warm and well perfused and their capillary refill is normal, they're perfusing. Their cardiac, because we don't have to deal with cardiac disease and compromise, things like that. So you can do this all very visually and very rapidly. ET tube. Is it in French? I think you're right. I've just assumed French. I think you might be right. We always say 4.0 tube, 5.0 tube. But I think you're right. It's not French. It's millimeter.
This would be like IV, little size.
Yeah. You're 100% right. Thank you for picking that up. You're the first person. I've given this lecture before. You're the first person to pick it up, and you're absolutely right. It's not French. It's millimeters. Thank you. Why isn't it changing? There we go. Okay. Did I go too far? Yeah. Okay. Here we go. Come on. We did that one. Why want to go forward? There we go. All right. If you're not working with kids that often, you don't necessarily, or if you're in the field, you probably don't put in NG tubes, but just for your own. We don't put in NG tubes very often. Now, why is that? Just so you know. Kids are vomiters. They're very sensitive, soft palate. If you try to pass an NG tube in a kid, you're probably more likely to cause more damage than you are to get what you need, especially if they're taped down and they have if they're in a collar and they're boarded. You try to pass the tube through their nose, they fight, they do this. You stimulate their soft palate, next thing you know, they're vomiting. And now you've got a vomiting child who's pinned to a stretcher, and you're off to the races. So we do, however, use it if we think that the abdomen is super distended. They are obligate air swallowers, kids are. Why? Because they cry like crazy. And when they cry, they swallow a lot of air. So you'll palpate them, and sometimes you'll say, oh my God, he's really distended. This kid is in real trouble. But if you were able to get an x-ray, what you would find is their stomach is like this big, and it just needs to be decompressed. And they will decompress it if you don't, but you don't want that. They'll just vomit. So if you see a big distended abdomen in a child, tap it. If it's hollow sounding and tympanic, then that's probably air swallow, and maybe you need it. We usually do it if we put a tube in them. Usually they're sedated. If their proximal GI tract is injured, or we suspect it, and then if we have to give PO contrast to a child, which we do more and more these days if we suspect a proximal injury. Rectal exams on kids, just a quick note. We don't usually do them. It's too traumatic for the kid. The kid can get hit by a car, and the only thing he'll remember is somebody violated him by putting his finger in their bottom. So unless we suspect a spinal cord injury or replacing a Foley, no rectals on little kids. Okay. How many of you use video laryngoscopy? All right. Do you do it in the field? How many do it in the field? Okay, so there's more and more. I have nothing against it. I think it's a great thing. My only concern, and I just bring it up, is what do you do when it doesn't work, the batteries? Intubating children is a skill set, and it's not all that much different than adults, but it is a little different. And I worry that if we rely on that, when you don't have it or you're in an austere environment, you won't know how to do it without it. So that's the only thing I would say. Use it, but make sure you keep up your non-video skills. Excuse me. Okay, what size tube do we use? Or what size laryngoscope? There you go. It's just a quick guideline. 6 months to 1 year, 1.5 years is a Miller one. We don't usually use max, especially in little kids. So let's talk a little bit about the mouth of a child. Depending on how you want to look at it, the tongue is big in comparison to the mouth, or the mouth is small in comparison to the tongue. I don't know. All I can tell you is, for many providers, if you try to intubate a child, the biggest struggle you have is all I get is tongue. How do I get this? I can't get this tongue out of the way. So we use a long finger like Miller blade, and that allows us a little bit more room to get that tongue out of the way. Thanks. Okay, so you can use Mac and Miller blades. Oftentimes we use a Miller blade like a Mac blade. As you know, the Miller blade is supposed to use to lift the epiglottis. The Mac blade goes in the vallecula. You can use them. We're not supposed to, but we use them either way. So it doesn't really matter. But this is, if you were setting up for a baby or something like that, Miller 1 will get you there. Miller 2 for the 1.5 to 14, and obviously above that, you can use the Miller or Mac 3. Okay? It gets you there. I'm trying to think, is there any questions about this? Yeah, if I were to watch people who don't intubate children very often, I could probably stand here and you could be intubating in the back, and I'd watch you intubate and I'd go, you're too far in, you're too far in. I don't have to see. All right, the most common problem when you try to intubate a child is you go in too deep, and you lift up the scope and you go, it's okay, be calm, just slide it right back. Just start to ease it back, and what you usually see is you'll see the epiglottis fall in your way. So be calm. And if you think about it, it makes sense. You don't intubate children that much, and so you're a little nervous, and you tend to go in deep, and then all of a sudden, I can't see anything. Just pull back, and the epiglottis will drop in your way. You're almost never too short. You're almost always too long. So just, if in doubt, slide the blade back, and it'll drop in place. And it's also, the airway is more anterior than you're used to in adults. So that's why good positioning is important. And when you lift, you've really got to do a nice lift at that angle so you can see. Okay? Where do I tape the endotracheal tube? How deep does it go is really the question. Now, in children, the space is relatively small. The landing zone for the endotracheal tube is relatively small, especially in younger children. So you got to be a little careful. This guideline, I like ET tube size times 3 because I can remember that very easily. If we put a 4 tube in, it's going to be roughly 12 at the K9. Easy peasy. That'll get you pretty close. Clearly, not only do we put the tube in at that level, then we listen for breath sounds in all the different places, and we listen for an air leak in children. Do you guys listen for an air leak in adults? Like, in other words, if you put a tube in an adult, do you listen for an air? Yeah. We remember that the narrowest portion of a child's airway is subglottic. In adults, it's right at the cords. But in children, it's subglottic, which is why for a long time we never used cuffed tubes. We still use cuffed tubes, but now they're softer. But that's the narrowest portion. So you just need to know that. And that's why we're pretty careful about where it's taped, because the landing zone can be quite short. No, we never used to, but they've developed soft cuffed tubes, so now we can use them even in babies. Am I doing something wrong here? Oops, there we go. I was probably not pointing it at the right place. Okay, so here's a picture of adult airway on the left. Everybody who intubates sees that. That's a picture of a pediatric airway on the right. You can see the obvious differences, okay? It's rounder. This is the epiglottis. It's, when I say a mega shape, it's short and fat around there. Not as much to lift. And the narrowest portion, like I said, is below. Okay, so, at least this is your visual reference if you've never really seen one, because you might have to do it. All right? Any questions about that? That makes sense? Oops. Okay, just a moment about medications. Everybody has their own cocktail that they are sure is the best, including me. So, I get that. And it's okay. If it works for you, it works for you. These all are recognized and approved medications. I just want to say a few words about some of these. Atropine, very important in children, way more important than usually in adults. Why? Because the cardiac output is rate-driven. So if a kid is in the 60s, you definitely want to give them atropine. What's the downside to giving atropine? Anybody got a clue? Why wouldn't I want to give atropine to a 4-year-old? Anybody? Guess? That's true. It dries them out, but that's not the problem. The problem is this. We kind of lose their exam. Remember I talked about heart rate? Heart rate? Well, if I give them atropine, their heart rate's going to be really high, right? And then I won't really know. Is he bleeding? Is he not bleeding? Did my 20 per kilo of fluid make a difference, all that kind of stuff. So that's the only downside. We still use it, and we do need to use it if there's a problem. Lidocaine for pre-medication, we don't usually give it IV anymore. We just squirt it in the airway. Most of us don't feel like it's that important. Kids' airways are reactive, but we would talk about, just have good technique and you won't have a problem. And it's another medicine to give. You can use it. We don't usually use it, and certainly not in emergent situations. Okay, what drug to use? Etomidate, ketamine, propofol, fentanyl, Versed. I'm an etomidate guy. I love etomidate. Now, you see up there one of the problems with it. Why? Etomidate works good for kids. It is a pretty stable medicine. It doesn't drop their blood pressure too much, anything like that. It's not a controlled substance, so it's much easier to maintain in your rigs, and you don't have to count it, and everybody's not crazy about it. It works pretty good. It's very short-acting. Now, let's talk about adrenal suppression. And this is a pet peeve of mine. We studied this at our institution many years ago because the ICU people were going crazy about adrenal suppression. But if you look at the papers that were written about it, it was all in patients with bad burns and horrible head injuries who have adrenal suppression anyways. So it's really hard to say. Our answer is get the airway first. We can worry about adrenal suppression later. And if we have to, we'll give a little steroids. But we want to get that airway. We want to get it fast. We want to get it safely, okay? Especially in head-injured children where we do not want to drop the pressure. All right? Ketamine, everybody knows about ketamine. We use ketamine a lot. We don't usually use it for intubation. We can. It's okay. And then fentanyl, Versed, no problem with that. Just be careful. A lot of respiratory depression and hypotension. Okay? So lots of different choices. They all work as long as you know how to use your cocktail. They're probably not much different than what you guys use in adults. You just obviously have to know the dosing. All right, as far as the paralytics, we use rock most of the time. We only use suck if we absolutely have to. You know, the non-depolarizers, 1 per kilo rock, he's pretty good. We don't have much problem with that. Yes. We used to go with sucks all the time. Yes. So we use sucks because sucks, first of all, there wasn't rock back then. You know what I mean? So we didn't have a short-acting agent, number one. Number two, we use sucks because the pediatric airway was difficult. And the one thing good about sucks is it's so short-acting that if you can't get the airway, you can usually bag them through sucks, you know. And now we have reversal agents for all the non-depolarizing agents. Yes, sir. You mean if you don't have the, what's the name of the, so if you're in an emergency and you have to intubate, you're saying that you would rather use sucks because rock, you don't have an antidote for rock? Is that what you're saying? No. You can bag mask them, right? Yeah. Right, without the need. So you're arguing that we should use sucks or we should use rock? I'm not sure. I would use rock, definitely. You would use rock?
He's saying you would use rock.
I would too. Yeah. I use rock all the time. That's what I'm saying. I haven't used sucks in forever, unless there's specific indications. Right.
You secure the airway, probably can't.
Yes. Right. Yeah, we haven't used sucks in forever.
I'm sorry, I didn't mean to create such controversy.
No.
I was curious, since you're a pediatric surgeon, you still hear a lot of pediatric surgeons prefer sucks, and I was just...
They're old and decrepit. Don't listen to them. No, I'm kidding. You know, some people will use suck for a real rapid intubation. It's a very fast onset. Yeah, but, you know. Okay, that's enough of the meds. All right, IV access real quick. How do we get an IV in a kid, and what size do I use? Kids are not little adults, right? We talk about that, except when it comes to obtaining venous access, and then they're exactly like little adults, all right? It's a mental challenge for those who don't do it all the time to put an IV in a child. You're not doing anything different. You're not doing anything different. Everything is just smaller, but it psychs people out like crazy, all right? So I would say if you know that, you've got 90% of what I want you to know. You can do this. You do it the same way. You just use smaller IVs and you move less. That's all. Okay? We know this kind of stuff, peripheral central versus interosseous. You guys probably won't use central access unless you're in a medical facility. Interosseous, I bet you, how many people here have done an interosseous? Almost everybody, right? It's pretty routine. How many here have done it without the gun? How many people have done an interosseous without using a gun? A couple. Okay. Yeah, most of the time we have that IO gun. That's a great thing. And we use it in kids. We use it sometimes in kids in the ICU when we have to because we can't get access because they're so collapsed. perk versus cut down. We perk pretty much everybody. The only people who would cut down are surgeons. And we only cut down when we have to. It's long, it's tedious. You can do it, but it's not easy. Okay, you've all heard this before. 2 large bore IVs, check your ego out the door. Here's the most important lesson here. I don't care how many initials you have after your name. If you're not the best person to put the IV in, let somebody else do it, really. There's almost always, without disrespecting any of my ER nursing colleagues, some crusty ER nurse has got 20 years of experience and it can put an IV in everything. Let her put the IV in. Just because you're a doctor means nothing. Let the best person, it might be a paramedic. It could be anybody. It could be anybody who is good. Check your ego at the door. These can be difficult, especially when they're hypotensive, and we have to get that IV in for meds. Okay? All right. Now, we say this. It's a guideline. This never really happens. Okay? We tell, no more than 2 or 3 minutes should be attempt getting peripheral access. That's really not the case. Unfortunately, if I don't tell you 2 or 3 minutes, I have to tell you something. And what happens oftentimes is people will spend 20 minutes, 30 minutes trying to get an IV in a kid, and that's not okay either. So as a team leader, if you're a team leader in a trauma, you have to keep an eye on this. Now, do I go at 3 minutes? Okay, that's it. We're going to some. No, we never do that. But I have to get a feel for, are we making progress? Do we have the right person? Usually we'll have multiple people try. We need at least one IV. We talk about 2 large bores. That's nice. If we can just get one IV so we can control the airway and give pressors if we need to, we'll go with that, resuscitate the patient, and then try another one. All right? Usually antecubital saphenous vein. We use a blind saphenous technique, and right here between the 3rd and 4th finger, there's a vein there, believe it or not, in kids that you can't see, but it's there. Okay, that's maybe a little different than in adults, but they're there. So we look for those most commonly. Okay, we talk about consider IO, cut down. You don't do the blind technique is very simple. You put your finger on the medial malleolus, you rotate it anterior, just your thumb right on the medial malleolus, rotate it anteriorly, you put a little nail mark there. That is your saphenous course. Okay? Then you start, you back off a little bit, you poke kind of right at that, a little more medial, a little more lateral, and that's how you usually find it. I probably do 2 a week this way in the OR when we're trying to get IV access in children. Okay? So I'm a big distal saphenous blind technique. You can do it. It's too hard to cut down. It takes too long. You don't have the equipment. Okay? This is great. We tend not to put them in here if we're going to leave them in there because then the kid can't flex their arms. In an emergency setting, it's great. Okay, just a basic ballpark. What size IV do I use? Okay, 1 week to 1 year, a 24. 1 year to 2.5, a 22. 2.5 to 8, a 20. There you go. Easy peasy. 24, 22, 20. Okay? Easy. All right, interosseous, this group, we don't have to talk about it. A lot of times in people who don't do EMS is way better than a lot of our pediatricians and things like that. But we know that they always have non-distensible veins in their tibia and other places. Okay? The only thing I would say is, people can sometimes go a little crazy with IOs. We tried twice to get a peripheral IV. Let's get the IO gun. And the kid is screaming. No, that kid will hunt you down and kill you later. No, really, that thing hurts. That's a big friggin' needle. That really hurts. If they're awake enough to bitch, then don't use an IO. Keep trying. Really, okay? You've got to give them time, and because it will hurt. And anybody who doesn't think so, have somebody put an IO in you, see how you feel. You will not want that. So if they're awake and, talking and, struggling a little bit, you probably have a minute. Now, if they're unconscious or they're unstable, you got to do it. All right, this is how we do it. We tend to do it in the tibia for kids unless there's a fracture, and my test question for the students is, tell me the meds that we cannot put through the IO. The answer is everything. So you can do all that. You can put everything through an IO and then a firm pop. You got to secure these really well. Otherwise, they come out. And we see that even in the hospital setting when we put an IO down in the ER and we're going up to the ICU. If you don't kind of build something up around them to hold them, somehow, gravity intervenes and all of a sudden it's out. Okay? So secure them well. We'll skip all this. Those are the contraindications. I talked a little bit about the brazolutin tape. Does everybody know what that is? Anybody not know what that is? Okay, it's okay. It works, and it's good if you don't no peds. If you're not doing peds all the time, they have them all over adult hospitals, this little Broslow cart in the background with color-coded that tells you everything. It's kind of idiot-proof. There's nothing wrong with it. It's fine to use. Obviously, some rigs that are primarily adult may use Broslow bags in the rigs. It's all good. It all works. It's all based on nomograms. So just be aware, if you don't do a lot of peds in your facility, but you need the access to critical peds, it's a good way to do it. All right, I'll just go real quick through this. All right, so this is, you can see, everybody see that big wide mediastinum on this kid that was in a motor vehicle crash. All right, how many want to get a CT of the chest for this kid? Nobody's concerned about a ruptured aorta? Big wide mediastinum? Why not? Who says no? Raise your hand. Come on, say no, because I know you say no. Why? The guy behind you.
You pointing at me?
Yeah, I'm pointing at you. You're the guy. Why do we not want, does he not have a, no, that's not the answer. Anybody else? This is the thymus. Little kids have a big thymus. So if you're not used to seeing little kid chest x-rays, this looks like a wide mediastinum. It's not. It's a normal mediastinum for a kid with a big thymus. So you just got to be aware of that. Okay, a little pitfall. I won't go through, this is an odontoid, this looks like an odontoid fracture. It's not an odontoid fracture, it's a growth plate, which we see in 2 and 3 year olds that you do not see in adults, okay? That's the difference. And the last one is this here. The kid was running, see, this doesn't line up well. Oh my God, he's got a fracture in his neck, right? No, it's called pseudosubluxation. We see it all the time in children. He needs nothing, okay? Just 3 quick little, why are kids not like adults? All right, I'm gonna quit in a second, but I want to just give a plea about radiation in children. At our institution, where we see 4,000 traumas a year, it's the 6th busiest trauma center in the United States. Nobody's here from my institution, thank goodness, because I'm just going to crap all over my adult colleagues. They scan everything. They scan, you walk through the door before you've given your insurance card. Head, neck, chest, abdomen, pelvis, and anything else they can scan. Of course, that may be okay for adults, but it's terrible for children. Children are younger, their cells are much more sensitive, they have a longer lifespan. We are very sensitive to radiation in children, as should you be. So my goal is to make you guys all protectors of the children by not overly scanning children. I give the example about the wide mediastinum because my adult colleagues would scan that patient, and it would be normal, and all the peds people would go, well, no shit, you dummy. Of course, that's just, so this is why we want to have these talks and explain. So radiation is bad, and we don't want to do it any more than we have to, okay? So try not to scan children unless it's really indicated. Limit the radiation and make sure that if you are at a place that has to scan a child, make sure you're using pediatric protocols. A lot of times, if you don't do a lot of kids, they just scan them on the adult protocols and they give them 3 or 4 times the radiation they need, okay? So now you can take all that back. All right, I won't talk about solid organ injuries because it's not hospital-based. And that's all I have. I'm happy to answer any questions that you have. Thank you for your attention. Yes, sir. No, I'm not saying don't scan children. I'm saying think about children like, well, I wouldn't even say this in adults because they give blood way more than we do. We always say, well, blood is a drug. Radiation is a drug. It has side effects. It has toxicity. Think carefully. And that's probably the biggest difference between PEDS people and non-PEDS people is everything we do to a child really impacts them, traumatizes them. I can draw blood on you and you'll go, I drew blood. You don't think. A child, that's a traumatic thing for them. So all the things we do have consequences in the children. And so we try to be very thoughtful about the test. And if there's one difference between PEDS and adults is we get way less stuff. We get way less blood tests, way less x-rays. We use clinical observation because it's not that we're smarter or better. It's just that the kids they tell us, you can tell by looking at them, being comfortable with them, knowing how they respond. And that's why we can get away with, much less. When we're in the trauma bay, a lot of times we'll walk in and it freaks out the adult people. We'll walk in, look at the kid, talk to the kid, take the collar off and pick them up and hold them. And they're like, oh my God, you didn't get, a CT of the neck. Yeah, he was running down the street. He's got a pediatric neck. They don't fracture that way. We just know from hundreds of years of care. We just know they don't do that. Okay? Any other questions? I'm around. I'm here all week. Try the veal. All right?
Thank you.
Yep. Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.